pleasure to announce Professor George Mastorakos from Athens University, and today his topic will be, let me see, for a transition of type 2 diabetes in menopause.
Needless to say, dear chairpersons, how happy I am to be here, invited by the organizers, and especially I would like to extend my thanks to Professor Inas Shaltut for this kind invitation, particularly for letting me visiting this beautiful country, which nobody could be ever fed up of visiting and admiring its thrilling locations of civilization. Okay. The idea is to try to discuss this situation, and as always in epidemiology, when we have to deal with pathologic entities which are encountered in great percentage in the population, we might have we might see associations which are mathematically proven, but they are not physiologically real. And this is the case, for example, when we have to deal with menopause, obesity, and diabetes type 2. They are all three situations encountered in high percentages in the population. So we will try to find a solution and eventually the physiopathological relationships in this triangular relationship, particularly when we deal with a parameter of age interfering in the situation of menopause and BMI interfering with the role of obesity. Okay. So we have certain parameters which emerge during the menopausal transition of a woman, which could have putative direct effects, but at the same time they could be confounders regarding the diabetes risk in menopause. For example, during menopause we have a relative increase of testosterone. Actually, absolute testosterone levels, they go down, but because SHBG goes down and at the same time the opposite effect by estradiol goes down, it appears that the androgenic environment increases. Then the rate of the decrease of estradiol increases body fat, decreases skeletal muscle mass. We have just discussed the importance of sarcopenia. There is increased central deposition of fat, increase of inflammation, which is a parameter which is particularly important in all these issues that we have just discussed, such as sarcopenia and PCOS, and definitely in the case of menopause. And then the role of the hormone therapy use, it has to be discussed. Other hypothesized confounders are age, smoking, alcohol use, physical activity, education level, and parity of the women. So you can see that this is a complex problem in order to decide whether there is a direct influence of menopause or even indirect regarding the risk of diabetes type 2. Definitely, in our days, because of the extension of the life expectancy, we're going to see more and more women, fortunately, to live a long period of their lives in menopause. So we'll have to deal with this problem one way or another. And the situation is that although we define menopause as the cessation of menses, actually, it's a situation which develops gradually with the decrease of estradiol levels and the increase of FSH levels. This is why there have been consensus conferences, such as this one, which has defined the stages of reproductive aging, a workshop, and out of this definition came out the acronym STRAW, and we all work with this in order to define the situation which happen, the situations which precede the cessation of menses, sometimes for many years. And this is why we define these stages as stages of straw. As you can see -5, -4, -3, -2, and -1 straw, where we can see the menses of the women varying in length. Let's take a look regarding the adipose tissue and menopause, because more and more in nowadays, the definition of diabesity incites us to consider diabetes type 2 as a prolongation of the deleterious effects of obesity. And adipose tissue is a key tissue when we need to study this phenomena. Here, for example, we have the epididymis of male animals, but they are male rats which have been knocked out for their alpha estradiol receptor. And epididymis, as we know, it's a location of segregation of adipose tissue. And we see that in animals with their receptor, alpha estradiol receptor knocked out, we see that there is an increase of their adipose tissue. So when estradiol goes out, adipose tissue increases in male animals. On the other hand, in female rats, when we perform ovariectomy, we see an increase of food consumption, increase of water consumption, weight increase, and then all these phenomena return to normalcy following estradiol administration. Now, estradiol administration to ovarectomized animals protects them definitely from weight increase, as we can see in this study of 2013. And here you can see how the weight of these ovarectomized animals which received estradiol did not go up. So what do we know about the role of estrogens regarding the direct and central effects having to do with adipose tissue? Regarding lipogenesis, we know that they decrease lipoprotein lipase, mRNA, and protein expression. Regarding lipolysis, they increase hormone-sensitive lipase activity and epinephrine-induced lipolysis. So when adrenaline, for example, during exercise is secreted, this is facilitated by the presence of estrogens. And site-specifically, they attenuate subcutaneous tissue lipolysis. Regarding adipogenesis, they increase adipocyte precursor proliferation, whereas they decrease expression of adipocyte differentiation factors. But the most important, to my view, this is why I have put it in this red rectangle, are the central effects of estradiol. Because estradiol decreases feed consumption, decreases leptin secretion, so consequently decreases insulin resistance, and increases activity and energy expenditure. And this is something that we see in women who are getting into menopause for unexplained reasons. Studies have been done many times. They decrease their activities even when they are incited to do so. And here you have all the traditional glucose metabolism pathways, including the cycle of Krebs, where estradiol plays a facilitatory role. So the role of estrogens in energy metabolism, the influence of estrogen on metabolic control is mainly mediated through estrogen receptor alpha. We have seen this with the epididymis of male animals. Binding of estrogen to ER alpha in infundibulum and arcuate nucleus amplifies the excitatory input on POMC neurons at the level of the hypothalamus. And we know that PMC neurons, they exert an anorexigenic effect.
Recording in
binding of
progress.
estrogen to AR alpha in
Recording stopped.
ventromedicular median nucleus in the hypothalamus again activates the transcription of steroidogenic factor 1, which plays an important role in the regulation of energy expenditure. So all this physiopathology about the role of estradiol and regarding its central role has been rather well studied and at a certain extent elucidated. The role of estrogens in energy metabolism. Estrogens seem to act as a powerful anorexigenic agent of the human body. However, both obese and non-obese menopausal groups had relatively equal estradiol concentration, so this suggests that there is potential influence of other factors on energy homeostasis, again, the confounding factors we were discussing in the beginning of this talk, such as lifestyle and daily dietary intake. Even more, it seems that FSH might be associated with increase in waist circumference. And when we administrate anti-FSH antibody, which block FSH action in the face of unperturbed estrogen concentration, there is a reduction of adiposity. So when, as we have shown in the beginning of this talk, FSH levels go up during menopause, it seems that eventually FSH itself might influence the increase of food consumption and reduction of energy loss. Now, here you see a traditional case of a woman suffering from Cushing disease with central visceral adiposity and the famous buffalo hump. But here, in a woman who had no Cushing disease, no Cushing syndrome, we can see again similar clinical characteristics with central adiposity and buffalo hump. And this is what we could call the phenomenon of simple obesity through life, and how this simple obesity is associated with a diabetogenic hormone, which is cortisol. And I like very much in my talks to put the experiment, or I would say animal observation having to do with the apes of the New World. These studies have been done in the late 80s of the past century. And these animals, they have a tendency, they are female animals, to create bands of animals which are characterized by social status hierarchy, where we can see a dominant female and a subordinate female. And interestingly, the subordinate females have been studied, and among all other characteristics of stress which is implemented to these animals, including, as you can see, poor ovarian function, which can be related to PCOS, we have just discussed a little bit before, they develop visceral obesity. And this visceral obesity is directly associated to their levels of cortisol, indicating their levels of stress. So we would call this social stress, which is involved through life, eventually with phenomena having to do with diabetogenic situations, including the fact that we know very well for many years, or I would say decades, that cortisol levels through life increase slowly. And so again, we have, excuse me, just please keep quiet, thank you. So these cortisol levels increase through life, contributing again to this diabetogenic situation. And we know also that we have differentiation between men and women in adipose tissue deposition, and women usually they present this gynoid lower body deposition of fat, which is subcutaneous and is considered not to be physiologically deleterious. However, this situation seems to change in menopause transition, where we have preferential abdominal fat accumulation and increased fat accumulation having to do with a deleterious visceral deposition. And this visceral deposition of fat is associated with the fact which I have stressed in the beginning of my talk, the inflammatory condition of these women. So in menopause, we have change of visceral deposition and increase of inflammatory characteristics such as CRP. Now, in perimenopause, where we have changes in body fat, we have changes in metabolism and menopausal symptoms, we have also markers which have been studied and are associated with the diabetogenicity, such as PI1 and interleukin-6, both inflammatory molecules, and both known to contribute to insulin resistance. So we have all the setting in menopause where the change of adipose tissue deposition, the presence of inflammation, facilitates the situation of increase of insulin resistance in order to facilitate type 2 diabetes mellitus. Let's see how this might happen. Indeed, the epidemiological data show that the later menopause happens, the longer these women are going to live, and the less their years are going to spend with diabetes mellitus. As you can see, for example, in early menopause, the expectation of these women to spend their life with diabetes type 2 is higher than the number of years that women with late menopause are going to spend with possible appearance of diabetes type 2. And the relative risk for type 2 diabetes mellitus per 5-year increment in age at menopause are negatively associated, meaning that the later the menopause is going to arrive, the less they are going to develop diabetes type 2. And this, again, very interestingly, is shown here in this big study with more than 3,000 postmenopausal women, where these 3,000 postmenopausal women were divided in 3 groups: those with premature menopause, early menopause, and normal period of menopause. You will see that in premature and early menopause, the relative risk of developing diabetes is multiplied by 3 or 2, whereas, as you can see, in a normal period of appearance of menopause, the relative risk is included within the 0 length of prediction, so there is no change from normal expectation. Now, there is, regarding obesity, there is an association between age and natural menopause and the risk for appearance of diabetes type 2, in this case in more than 2,500 women. And you can see that in non-obese women, the risk of diabetes type 2 appears later in life, whereas if these women are obese, they have the risk to develop this diabetes earlier. And when we combine these factors, again, in this 2019 study, in obesity and with early age, the relative risk for diabetes type 2 increases, as you can see clearly here, even in women less than 45 years of age. So these 2 factors, again, age and obesity, seem to interfere with the facilitation of development of diabetes type 2 in menopause. And we know very well from physiopathological point of view what happens when estradiol binds to its alpha receptor, as we have said. It blocks lipolysis, so no free fatty acids circulate, or at least their level decreases. And as you know very well, through all these physiopathologic mechanisms, when we have lower free fatty acids, we have decrease of insulin resistance, and so less risk for development of diabetes type 2. And again, the insulin markers follow this idea by increase of hyperinsulinemia and C-peptide in women who develop metabolic syndrome during their menopause. And even there are other pro-inflammatory mediators, such as this molecule, which is one of the molecules of advanced glycated molecules, and CRP, which again defines inflammation. So we see that in women in menopause with diabetes type 2, we have again this inflammatory phenomena. And this is very interesting because it appears that this is very particular characteristic of women in this advanced stage when they are compared to middle-aged men in this very interesting study only recently published in Brazil, where we see that men with increased glycemia, they show more or less recently appearing increased glycemia, normal microvascular function, whereas women with increased glycemia, they have a tendency to show impaired microvascular function with decrease of adiponectin and increase of CRP and increase of ages, as I have already shown to you. Now, to come to the end of this presentation, is it possible that by administering estradiol to these women, as we are discussing many years now in post-menopause, this could facilitate the decrease of their relative risk for diabetes type 2? Yes, it seems, as we have seen before, that the administration of estradiol to ovarectomized rats decreases hyperinsulinemia, so it shows that it decreases insulin resistance. Also, the administration of estrogen to these rats protects them from fatty liver infiltration and the development of production of free fatty acids, and we have seen how important this is. Now, what we know in humans we know that when we administrate transdermally estradiol, we have decreased levels, or the changes of triglycerides levels, they do not change, do not happen, and there are no influence in their clotting factors, whereas when we use conjugated estrogen or just estrogen 17 estradiol orally, then we have increase of triglycerides, something that we do not want. So if we were prone to suggest a treatment in these women which eventually could also be beneficial for their tendency, their risk to develop diabetes type 2, that would be transdermal administration. And so let's summarize this by saying that endogenous estradiol has beneficial effects in insulin secretion, insulin sensitivity, and glucose effectiveness, as well as energy expenditure and adipose distribution. These beneficial effects are lost in menopause. The negative effects resulting from estrogen withdrawal in menopause can be improved by hormone therapy, which decreases the incidence of type 2 diabetes mellitus, but this needs further evidence to be produced. And we even know that even phytoestrogens seem to have positive effect. They are associated with decreased HOMA index, and also they are associated with decreased risk for type 2 diabetes mellitus. And in conclusion, the percentage of menopaused women in the female population is increasing worldwide. The decrease of estrogens in pre and menopause leads to decreased satiety and energy expenditure. So these women, they spend less energy and they eat more, and increased insulin resistance and BMI. The relative risk for developing diabetes type 2 in menopause decreases with age and increases with age of appearance of menopause, and increases with BMI. Alterations in pro and anti-inflammatory mediators are involved in microvascular dysfunction, particularly in postmenopausal women with type 2 diabetes mellitus. And although hormone therapy is not approved for the prevention of type 2 diabetes mellitus, I must stress this point because in the guidelines and the different consensus regarding hormone therapy, there is no notion regarding prevention of diabetes type 2. However, due to its complex balance of risks and benefits, of this treatment, however, it should not be withheld from women at increased risk for diabetes type 2. Of course, we have always to consider whether they are in or deleterious obesity, where there is a risk of increasing thromboembolic phenomena. But we have to consider it for women with increased weight in menopausal symptoms. Now, whether the increased risk of type 2 diabetes mellitus is a direct or indirect effect of menopause, as I have presented to you in my initial slide, to my view, it's still an open question, and we need more studies having to do with the physiopathology of this phenomenon. Thank you very much for your attention.